Dr. John Slutzman is an environmental engineer and emergency physician. He is the director of the Center for the Environment and Health and the medical director for environmental sustainability at the Massachusetts General Hospital, as well as a practicing attending emergency physician at MGH. Prior to a career in medicine, Dr. Slutzman was a consulting environmental engineer, completing projects in a variety of areas within environmental health and safety assessment, straddling the line between engineering and medicine. His mission is to improve the environmental sustainability of healthcare delivery, aiming to reduce the environmental cost of healthcare. His academic focus is measurement of environmental impacts in healthcare, particularly using life cycle assessments. He is a founding member and chair of the Mass General Brigham Clinician Sustainability Group, a past chair of the Society for Academic Emergency Medicine, Climate Change, and Health Interest Group on the advisory, sorry, let me read that again. He's a founding member and chair of the Mass General Brigham Clinician Sustainability Group, a past chair of the Society for Academic Emergency Medicine, Climate Change, and Health Interest Group, on the advisory committee of the Healthcare Without Harm Physician Network, a founding member of the MGH Executive Sustainability Committee, and a founding member of the Mass General Brigham Climate and Sustainability Leadership Committee. So welcome to Dr. Slutzman. Thank you for coming again. We appreciate your support. Thank you very much.
Thank you very much, Dwayne. So first of all, I can't see anybody past like the second row of tables because of the lights. So if you want me to be able to see you, you can totally move forward. There aren't too many people in the room, and we can make this more of a conversation. No pressure. You're welcome to move forward. You don't have to. I'll still talk. Second, show of hands, who was here last year when I talked? Okay, a few people. That's great. For some of you, there'll be a little bit of review. For the rest of you, I hope you're going to learn something interesting and useful for your work. As Dwayne said, I am the Medical Director for Environmental Sustainability and Director of the Center for the Environment and Health at Mass General, where we strive to insert environmental thinking into all aspects of the hospital mission, which increasingly means working at the health system level, where I get the privilege of really getting to know and work on a regular basis with many of the folks on our supply chain teams, whether it's at the local hospital or at our enterprise institutions. So it's really, I think, imperative that your clinicians, your environmental professionals, and your supply chain team all get to converse with each other and learn from each other to make our practice a bit better. So I'll start by saying, has anybody experienced anything new in your work in the last year? Anyone? Anything new? I was here for half of the last talk, and clearly there are changes that have happened in our ecosystem of healthcare delivery and governmental regulation, and some of those may or may not be better for human health. So what I'm going to talk about mostly is how at least some of those changes don't really matter. That we have a mission that we still aim to fulfill. We're still in this business for the same reasons, to improve human health and to protect human health. So those changes external to us really shouldn't matter as much as I think people make them out to. But at the same time, they might perhaps change some of the conditions and constraints that are put on us as we try to achieve our missions. Let's do a little bit of review here. Why is an environmental engineer talking to a bunch of supply chain, medical device manufacturers, suppliers, GPO reps, and so on? There is no doubt that over time, our planet is getting warmer. The evidence is abundantly clear. I'm not going to debate it. That has impacts on what we can and can't do, and the, no pun intended, environment in which we have to deliver our care and operate our enterprises. 1 degree might not seem like a lot, but if you'll look more carefully from 1880 to 1980, over 100 years, there was really quite minimal overall variation in global temperatures. And then starting in about 1980, we see a much faster increase. We also know from 800,000 years of data, and I can talk later about how we know those kinds of things, that the concentration of carbon dioxide in our atmosphere has increased from a stable level in the high 200s part per million around to, so we're well over 400 parts per million now, which, again, parts per million are small, but think of it less as 200 parts per million increase and more as double. And if I put twice as many blankets on your bed at night, you'd probably be a bit too warm. That's kind of what's happening. So why do I, as a physician, that's why I, as an environmental engineer, but why do I, as a physician, care about this? Well, I care about people dying, or more accurately, dying less. I spend my nights in the emergency department at Mass General Hospital fighting Darwin and trying to keep people alive and improving their health. These are global death rates. On an annual basis, heart disease kills about 18 million people. Cancer kills about 10 million people. Lung disease, chronic lung disease, kills about 4 million people. Air pollution kills about 7 million people. That's just criteria air pollutants. That actually doesn't even include climate air pollution. It also doesn't include soil pollution. It doesn't include water pollution. There are lots of other kinds of pollution this doesn't include. Just air pollution, roughly 7 million people. There's a lot of money and effort and research that goes into cancer and heart disease, rightly so. But not a whole lot of attention is going to the fact that pollution is killing people. And we actually can prevent it or at least mitigate it. Like I said, that's just non-climate air pollution. 125,000. That's a relatively large number, depending on what we're talking about. That's a number of people. That's a number of people in the United States who die annually because of climate pollution from healthcare. So just greenhouse gases from hospitals and the ecosystem of industry that supply hospitals kills about 125,000 people a year. I'll dive even more deeply. In my health system, if you average it out over the course of a year, we kill about 1 person a day because of our greenhouse gas pollution. If I went to my vice president for quality and safety and said, you know, there's something we're doing at our hospital that's killing a person a day. We're botching a surgery, or we're giving the wrong drug, or we're making the wrong diagnosis. Something is happening. It's the same thing day after day. We're killing 1 person. That vice president for quality would be aghast and would say, all right, well, we need to stop that. We need to do something to make that better. And she would be right. But we don't seem to have that kind of imperative, that kind of fire under our butts to do something about pollution from healthcare, which is killing these people, the same way that medical errors unfortunately kills people as well. So how can we know about it? What should we be doing about it? How should we think about it? And the way that I think about it is sustainability. I said I introduced myself and Dwayne introduced me as the medical director for environmental sustainability. What does that even mean, that word sustainability? And it's this absolutely crazy concept that we should act in the current generation to meet our needs and wants and desires and fulfill our lives in a way such that future generations can continue to do the same thing. How can we act so that future generations have the same opportunities that we have? In other words, living within our means, right? If you spend all of your money today, you might have trouble buying food tomorrow, so you don't do that. Well, if we pollute our atmosphere today such that generations later aren't able to breathe safely, live as long lives, have fulfilling opportunities, well, that's not very sustainable either. So we should think about it in that way. How can we do things a little bit better? Now, neither Dwayne nor I promised that there would be no science or math here, so there will be. And I need to cover a little bit that hopefully will be review for many of you. If it's not, that's okay. In order to talk fluently in sustainability, we all have to be a little bit on the same page. And the Greenhouse Gas Protocol, which is the international standard for how to measure and report climate changing pollution from entities, from companies, from cities, from the planet, defines our emissions, our pollutants, into 3 categories. They're called scopes. Scope 1 are direct emissions of greenhouse gases from your facility or places under your control. I like to talk about an analogy of your home. Hopefully, we all have a comfortable home. In my house, I have a gas-fired furnace. It heats my house, and the emissions, the pollution from that gas-fired furnace include carbon dioxide and some carbon monoxide probably and some other pollutants. That pollution from my furnace is a Scope 1 emission. It's direct emission from my facility. I drove here just now. I own my last gas-powered car, and I drove down from Greater Boston this morning. The tailpipe emissions from that car are my Scope 1 emissions. Scope 2 emissions are indirect emissions from purchased energy. It is a carve-out. So in my house, I have electricity. It comes into my house from the grid. The generation of that electricity generates pollution, and those pollutants are my Scope 2 emissions. Incidentally, I actually buy 100% renewable electricity, different story, but if I didn't, those would be my Scope 2 emissions. Scope 3 is everything else. So I buy food for my family. To grow that food requires fertilizer and equipment to plant and harvest and shipping. All of the pollution that comes along that supply chain are my Scope 3 emissions as I buy that food. And then hopefully my children eat it. So in a nutshell, everything is 1, 2, or 3. 1, direct emissions from your facility. 2, indirect from energy that you buy. And 3, everything else. How does it break down here in healthcare? We have some great studies looking at this, and I'm going to pick on 2 data points today. One is from NHS England, the National Health Service in the United Kingdom. They are the world leaders in environmental sustainability in healthcare. They're really great. They've been doing inventories for years, and this is their breakdown from their entire health system. And it's not really important what the absolute numbers are. It's not really important how they may or may not do things differently than the way we do here in the United States. But the important bit is that 62% of their emissions come from the supply chain, which is all of you folks sitting here in this room. 62%, that's a big fraction, right? And this is a place that has physical hospitals that are actually relatively old among industrialized nations. Their infrastructure is old, so they're inefficient. But even with that, 62% comes from their supply chain. Lest you think that they are an outlier, more local numbers. These are the actual emissions number from my health system from last calendar year. And we literally just finished calculating them a month ago. So cool off the press. And what you see here is the 3 scopes split into colors. So black are Scope 1, blue is Scope 2, green is Scope 3, the gray is the total. We emitted approximately 1.5 million metric tons of carbon dioxide equivalents from Mass General Brigham facilities. To put that in perspective, that's about 350,000 cars in the United States, or about 200,000 homes. So it's a lot. Another way to look at it is healthcare in the United States is responsible for between 8 and 9% of total greenhouse gas emissions. So we're pretty intensive. My health system, not much different. There are some things about my health system that are a little bit better than average. So our Scope 2 number is particularly low for the size of our facilities. And that's because we buy 80% of our electricity from renewable sources, the majority a wind farm in New Hampshire. And we heat at least our largest campus with quote-unquote waste steam from a cogeneration plant in Cambridge. So our Scope 2 emissions are pretty low. Our Scope 1 emissions are okay, kind of middling, but that leaves Scope 3. And I want you to focus your eyes on the two biggest bars that you see there. Again, the absolute numbers, less important, but those two biggest bars are PGS, is purchased goods and services, and the second one is capital goods, so renovations. Those two put together are most of our supply chain. And our supply chain together is about 75% of the total. 75%. That means I cannot reduce my emissions at Mass General Brigham more than 25%, and that's if we get everything else to zero, without engaging with our supply chain, both our internal supply chain team and all of our suppliers, all of our pharmaceutical suppliers and our medical device manufacturers and so on down the road. We're not alone in thinking about this. There are a lot of other health systems. I mentioned the NHS. If you want to pick on the big ones around the United States, Kaiser Permanente, Providence Healthcare, Advocate Aurora, NYU Langone, Cleveland Clinic, many others around the country, the entire UC system, are really leaders in the healthcare environmental sustainability space. So what I would say is that if you want to either continue selling to many of those systems or get a leg up against your competitors when selling to some of those systems, environmental sustainability could be your differentiator in a way that cost becomes more and more difficult to differentiate. I mean, honestly put, there comes a point at which you just can't compete anymore on cost because things just cost what they do. But maybe you can compete by showing that your product is better in other ways. And environmental performance is absolutely a way to show that a product is better. And health systems aren't alone in doing this. There are industrial organizations. CHARM is one that started about a year and a half, maybe 2 years ago, I want to say at most. The Collaborative for Healthcare Action to Reduce MedTech Emissions, basically what it sounds like. It's led by the Sustainable Purchasing Leadership Council. It's got a bunch of participants, both on the healthcare delivery side as well as on the manufacturer side, and GPO with Vizient taking a leadership role. And they chose to focus on 5 different areas in their first couple of years: product innovation, product durability, single-use device reprocessing, renewable energy, and sustainable procurement. And what you see here are some of the items of progress that they have made in about 12 to 18 months. It's not perfect, but you see that there is movement even in the current regulatory landscape and even with current financial pressures on the purchaser and manufacturer sides. CHARM will continue to do their work. I work with some folks who sit on some CHARM committees and are in their leadership core, and they are committed to improving performance in each of these 5 areas. And I'll pick on the UK again. Anybody here sell to the NHS? I'm curious. Nobody. Okay. Well, if you did, in the next 2.5 years, you would be required to report product-level greenhouse gas emissions, or they're going to stop buying your products. And they're a pretty big market. They're the largest national health system in the world. And I think that you're going to find that some other places might similarly favor companies that are able to report their emissions on an individual product level as the ideal, and product lines or facilities if not. So at least a couple of you are sitting there thinking, yeah, sustainability sounds great, but we don't have the money for it. Why should we do it? Our customers aren't all asking about it. And we have so many other pressures right now, which is all true. But there are a lot of reasons that we do this. So we at Mass General Brigham sat down a while ago and said, why do we care about environmental sustainability? And I mentioned I care about patient deaths. I care about patients' health and well-being. That's why I do what I do. But there are a lot of other reasons that we engage in sustainability. It complies with rules, and I'm going to touch in a moment on some other rules that are not coming from the federal government but are still just as important to us and other health systems around the country. It improves our finances. Now, some of you might laugh at me and say, no, sustainability costs money. I'm going to pick on a couple of examples later and tell you how we're actually saving money. Environmental sustainability, until you are pretty far down the road, which I welcome anybody who gets that far down the road. We are not there yet. Until you're pretty far down the road, almost everything you do in environmental sustainability will save money. It might not save money today, but it will save money, and they all have a positive ROI. So it improves finances. It builds your brand. It pays to be the supplier or the provider who is doing better when it comes to the environment or protecting human health. It can dovetail with other priorities, particularly for us at Mass General Brigham. We have a strong focus on equity and ensuring that we treat all of our patients fairly and equally, regardless of their origin or where they live in Greater Boston or New England. And it turns out that polluting less kind of fits that priority. It can position your organization as a leader in what I still consider to be an accelerating space. I saw a headline this morning that I actually agree with, that Bill Gates came out and said that humanity will not die out because of climate change. That is true. I'm pretty sure that's true. But that doesn't mean that we can't do better, and it doesn't mean that the generations that come after us aren't going to be more and more interested in what we're doing about it. So this will continue to be a growing and accelerating space, and you as an organization can be seen as a leader there. It promotes resiliency. I don't know how many of you were exposed or had to respond to a lack of IV fluids after hurricane last year that wiped out North Carolina, Western North Carolina. We certainly had to respond to that and deal with it. It's not the first time. In fact, we've seen this happen before. Well, it turns out that there are other supply chain shocks that can happen, and the more sustainable choices you make almost always line up with the more resilient choices that enable you to keep operating. It supports employee retention and recruiting. Our generations below us only care about this more, and as we strive to recruit folks, we know from plenty of surveys and plenty of actual movements by employees over time that they want to work for a place where their mission aligns with what they see as important. And sometimes that can be more important than salary. Maybe not huge differences in salary, but some differences. So if you're worried about recruiting your workforce and retaining your employees and how hard it is to deal with turnover, this is one strategy as part of a portfolio. And then number one by far is that it aligns with our mission and values. We care about protecting human health. I challenge you to find a medical device or pharmaceutical manufacturer that does not say that their mission is improving human health. Number one. I looked at a few, I'm not going to name names, but pretty much they all say that. And we can be cynical and we can laugh, oh, that's not actually their primary goal, but it's a stated mission, and I bet that's why people work there. So just as it's my mission as a physician, and it's my organization's mission as a healthcare provider, it's our GPO's mission too, to supply us and to improve human health. And it's our pharmaceutical manufacturers and our med tech companies. It's all of our mission. So if it's truly our mission, we should make it our holistic mission, and we should be honest about it. I mentioned that the federal government certainly is getting out of this space. I'm not going to claim that they're not currently, but they're not the only players. And what we're seeing is more and more action on the state and local level. What you see here is a map of local places that either have enacted or are working on enacting building-specific pollutant or greenhouse gas emissions regulations. I work in Boston. Boston has had BERDO for a number of years. It's the Building Emissions Reporting and Disclosure Ordinance. It's now on version 2, which actually comes along with it what they're terming alternative compliance payments, and what any other normal English-speaking person would term a fine or a tax if you don't meet their standards. As in, if you're a commercial building over 10,000 square feet, you have to report, and depending on what kind of a building you are, you have to meet a certain emissions target. And if you don't, you're going to pay for it. Well, it turns out that if Mass General Brigham doesn't meet that target, we're going to pay a lot of money. So that gets people's attention. And we're actually on track to meet the targets and not have to make any alternative compliance payments. But we've paid a lot of attention to Boston. Cambridge is doing it. The city of Newton is doing it. And as you can see, other places around the country are doing it as well. So our healthcare organizations there are paying attention and caring. Anybody here operate in California? Seriously, only one? Okay. 2, 3, okay. So the state of California was the first to require all companies above a certain threshold to report their greenhouse gas emissions, as well as their climate-related financial risks. That reporting requirement is coming very fast, in about 2 months. So it starts in January of 2026. The thresholds are different. So climate-related financial risks, any entity over $500 billion, and greenhouse gas emissions, any entity over $1 billion. But they have to be reported. They have to be reported publicly, and they have to be reported either annually or biennially, depending on the requirement. So if you're doing business in California, even if you're not headquartered in California, you're going to fall under this, and many of our medtech companies easily fall under this. Our hospitals certainly do in California, and again, it's yet another requirement. There are at least a handful of other states that are watching California for their lead. Washington, New York, New Jersey, and I want to say Illinois are looking at similar requirements and bills. So if you're in any of those states, you might be seeing this in about, let's say, a year or two to follow. What do we do at Mass General Brigham when it comes to the supply chain? You don't need to read all of these questions. In fact, if you're one of our potential suppliers or you bid on one of our RFPs, you're going to get them all in a questionnaire, because what we do is we include sustainability language in every RFP that goes out. And we use those answers as part of our evaluation process. Does that mean that we are going to say, well, company A is better sustainably than company B, but company B's product is clinically far superior, we're going to choose company A? No, it doesn't mean that. It just means that we use a number of criteria to choose our vendors, and sustainability is one of them. Finances are another. Clinical quality, effectiveness, and safety, certainly others. But we include this in every RFP for a reason, and we do compare them. And the way we compare them is in this hierarchy. What I want you to think about is, can I get to a place where I can submit a proposal with products that say, this bag of IV fluid or this trocar or whatever other device costs X dollars and has Y greenhouse gas emissions attached to it on an individual product basis? Because the first company that does that wins, and I will firmly tell you that any company that does that, regardless of what the number actually is, will be looked upon favorably by my organization from an environmental perspective, as well as so many others around the country. Short of doing that, there are other things that you can still do. Can you report your emissions from a product line or from an individual factory or from the company as a whole? Are you reporting publicly to a repository such as CDP, formerly known as the Carbon Disclosure Project? Can we get those reports? Do you have a sustainability commitment? Do you have a plan? Do you have anything that we can review? And that hierarchy is important because the more you're doing, the more favorably we're going to look at it, and the more we're going to think, oh, we can partner with these folks. We're on the same page. They're doing a good job. Let's move forward. What else can you do? What else can you do? And here at Yankee Alliance, there is a sustainability committee that can get together and can advise members, suppliers, purchasers on different sustainability aspects and can set guidance and targets and policies. So if you're interested in this subject, please talk to Dwayne, because I bet he would love to have you to be a partner and to move the entire organization forward when it comes to environmental thinking. I'm going to close on with two stories. Dwayne specifically asked me, he said, I want you to tell stories. So I'm going to tell two stories. And these are real stories. These are not made up. In fact, this one even has a real picture that I took. And these stories involve partnership between clinicians, environmental sustainability professionals, materials managers, buildings and grounds personnel, and our supply chain team. Those folks all working together are what enabled us to do some, what I think are pretty great things that took work, but are going to improve our environmental performance, are going to either maintain or improve our patient performance, and are going to save us money. Anybody know what this picture is? Yeah, what is it? It's a nitrous oxide tank. It is. It is one of the two largest nitrous oxide tanks in New England at healthcare facilities. It's 12,000 pounds in capacity. The only other place that I know of in New England with a tank at a similar capacity is Maine Medical Center. They also have a 12,000 pound tank. And it, in this photo, is sitting directly outside one of the buildings on the main Mass General campus. And that tank supplied all of the nitrous oxide for our operating rooms. And we do a boatload of operations. We have 70 operating rooms. They're operating 7 days a week. And we hopefully do great things for our patients, and our anesthesiologists are able to use nitrous oxide as much as they think it is clinically warranted. In a given year, we would buy a certain amount of nitrous oxide. I don't remember exactly how much it is. It's a lot. We would pay a lot of money for it. It would get delivered usually 3, maybe 4 times a year to fill up this tank. So we took a look with our anesthesia folks and said, how much are we using? Well, conveniently, our anesthesia machines are connected to our EHR and automatically tell us. They track on a minute-by-minute basis all of the gases going into the patient. So we can then just run a report and say, how much nitrous oxide did we give patients in 2024? And it turns out that if you compare the nitrous oxide that we give patients to the nitrous oxide that we buy from Airgas, because they happen to be the vendor, the difference is 90%, meaning of the gas we buy, 10% goes to patients. I don't know where the other 90% is. It could be leaking in pipes, it could be leaking from this tank, it could be leaking from the manifold, it could be Bob from Buildings and Grounds having fun at home. I have no idea. But I know that we're buying a whole lot of nitrous oxide and 90% of it is going to waste. Eventually it goes into the atmosphere. All inhaled anesthetics are not really metabolized by people, so they all just get released into the atmosphere at some point. Whether it's immediately or an hour later, it doesn't really matter. It all gets into the atmosphere. Nitrous oxide has a global warming potential of 298. That's 298 times more than carbon dioxide. So 1 pound of carbon dioxide is equal to, or 1 pound of nitrous oxide is 298 pounds of carbon dioxide when it comes to warming. So we said, wait a minute, can we do better? And the answer was yes. So that tank isn't there anymore. Last January, we removed it. We spent 6 months on E-cylinders, on individual nitrous oxide cylinders, serving our ORs. Our patients never noticed the difference. Our anesthesiologists barely noticed the difference. There were a couple of changes to their workflow that we had to account for. And we tracked the gas in the tank because we needed to show that actually disconnecting the anesthesia machines was going to solve this problem. And wouldn't you know it, before we switched to E-cylinders, on average, the tank was going down by about 19 to 20 pounds per day. After we disconnected all of the anesthesia machines, the tank was going down by 21 to 22 pounds per day. So somehow, by turning off the anesthesia machines, we were using more nitrous oxide. And by using, I really mean it was leaking somewhere. So that sealed the deal, and we removed the tank. Nitrous oxide in E-cylinders costs more than nitrous oxide in a bulk delivery. But we're using 90% less of it, or I should say purchasing 90% less of it. We also don't have to maintain the central system. So all of the plumbing folks who would have to do regular maintenance and inspections and the annual certification that we needed to keep the system running, we no longer need to do. Is it saving us a lot of money? No. It's 5 figures a year. But it's not costing us anymore. And it's better for the environment. And it turns out that it actually hasn't been a large workflow change for our anesthesia team, because you might think, oh, those E-cylinders, we're going to run out of them. They need to be changed often. The OR that needs it changed the most often, it gets changed once a month. Other ones are even less frequently. So it can be done. It didn't cost us very much. It's saving us money. We actually have a payback period. The payback period is less than 1 year. I think it's about 6 months. So we did it, and it was through a good partnership. The other example is this. A bunch of you, I'm guessing, know what this is. Who knows what this device is? Yeah. It's a laryngoscope. I'm going to quibble a little bit. It's actually an AI-generated image of a laryngoscope. If you look really carefully, it can't possibly be used. But that's beside the point. I wanted to see kind of where that would go. And it's a laryngoscope, and we use a boatload of them at our institution. About, I'm going to say 5 years ago, our hospital switched from tried and true, durable laryngoscope handles with durable laryngoscope blades that we sent to our central sterile processing center for reprocessing after each use. We transitioned to single-use disposable laryngoscopes. And I'm not going to lie to you, I hate them. From an actual operator perspective, they are less good. They're less sturdy. They're not as comfortable to use. But environmentally, they're absolutely horrible. They have batteries. They have a small amount of electronics. They're relatively heavy. And it's kind of ridiculous that we buy one and we throw it away. But we did it. We switched to the disposable ones. And some of our anesthesia colleagues, as well as our sustainability team, have been working for at least 3 years to go back to reusable. And the question became, why did we switch in the first place? It's not primarily because of the cost. In fact, if you really look carefully at the cost, it's at best a wash. It's issues with following the IFU for proper cleaning and reprocessing. And I'm going to point my finger a little bit at some of our manufacturers, without naming any names, that it is relatively easy for a manufacturer to set a requirement for cleaning and either high-level disinfection or sterilization that is stricter than it truly needs to be for patient safety. Because from a manufacturer perspective, there is little downside and there is only upside. Because if your IFU says to do X, and the facility can clearly show that they did exactly X, and somebody gets sick, well, then the manufacturer is on the hook. But if your IFU are super strict, well, then you don't need to worry about that as much. Even better, your IFU says it's a single-use device. Well, now it's gone entirely. So we had issues with that, where essentially our reusable handles were being instructed that in order to reprocess them, we had to completely disassemble them and then clean and sterilize them. And from an operational perspective, that is just impossible. We cannot disassemble 100,000 laryngoscopes or 100,000 times for our operations. So that's really why we went to the disposable ones. About a year or two ago, we found on the market a laryngoscope handle and blade that is labeled for multiple use and has IFU that do not require disassembly for high-level disinfection or sterilization. Great, we said, fantastic. We can go to infection control, we can say, we found one, here are the IFU, it says we clearly can do this, our central sterile processing can do it, our anesthesiologists want to do this, it's gonna save us money, let's go ahead and do it. And the answer was, no, absolutely not. So what changed? I'll tell you, I'll skip ahead to the end part. In January, we're implementing reusable laryngoscope handles and blades at both of our academic medical centers. We're holding off on the community sites until we see how it goes, because we have to handle transporting to a central sterile processing facility, whereas the AMCs have them. So in January, we're switching, and what really changed was the finances. So when people say sustainability costs too much, I will turn around and say, we're switching laryngoscopes because it's gonna save us mid-six figures just at one hospital. I challenge anyone at any healthcare organization who doesn't want to save at least $100,000 a year. We got rid of the nitrous tank, and it's saving us less than that, a lot less, actually. Comparing the nitrous tank to laryngoscopes is about an order of magnitude. But we're doing it because the organization is certainly focused on finances and has realized that, well, we can clean these. The IFU clearly say we can. Our sterilization people say they can. Our operators want to use them, meaning our anesthesiologists. So maybe it's time for infection control to get on board. And that's where that team approach, again, in this case, anesthesia, sustainability, infection control, and what we call sustain, which as our stewardship and financial improvement organization within the institution, basically got together and said, look, this just makes sense. It doesn't help us if we can't provide care to patients because we're running out of money. That harms patients too, just as infection risks can potentially harm patients and pollution risks harm patients. So what I would say is all of the arguments against sustainability have a little bit of a grain of truth to them, but there are mitigating factors that we should talk about and go into with open eyes and be honest as we sit together and talk. Because in the end, we have a mission, and our mission is to take good care of people. And at some point in our lives, we're going to wake up one morning and say, what did I do? Did I leave this place just a little bit better than the way I found it? Because in the end, that's really all we have. So I'm happy to take your questions and stick around for any conversation you might have. Thank you. Yeah, so Dwayne asked, what do I think is the best way for sustainability and supply chain to engage, to find ways to work together? And I don't know that I can tell that there is one best way. I think each institution is going to be a little bit different. What has worked for us is a couple of things. One strategy that has worked is sustained, no pun intended, sustained conversation over time, where we have a purchasing sustainability subcommittee that meets monthly, and it's made up of our director of materials management and our executive director of perioperative services and a representative from our pharmacy and a facilities rep from one of our satellite sites where things are a bit more bunched into one person's job. Sustainability and then enterprise supply chain. And we get together monthly and say, okay, what are the projects that we want to work on? What are the pain points? We also use that as a forum for some of our vendors. Anytime a vendor wants to come to us and say, hey, we want to talk to you about our environmental performance, we say, great, you're going to present at that meeting. And we have some folks here who have, I think, done so. So we have that slot. Every month we get together. It's an hour slot. Sometimes it's quick, sometimes it's long, depends on how much we have to talk about. But really, after many months of basically sitting together and talking about things, we yielded great gains. And the way I describe it is, basically every month there'd be a discussion. I'd raise my hand and I'd say, have you thought about sustainability on that? Or what do you think is the environmental impact of that? And that led to one of our biggest gains in sustainability was when, here's a little tangent to another story, but it illustrates the point of sustained conversation. Our chief of thoracic surgery, and I told this story last year, our chief of thoracic surgery wanted to bring disposable bronchoscopes into our ORs. The request went to our director of perioperative services, whose first thought was, that doesn't sound very sustainable. I'm going to ask Dr. Slutzman what he thinks. And that led to a whole conversation. So sustained conversation with questions about sustainability has led to that working relationship where kind of everybody around the table understands what everybody else's job is and what their priorities are and can really talk to those concerns. And it's very collaborative. It really is super collaborative that we're trying to get to the best answer for our patients and the institution rather than the best answer for me as an environmental engineer or for Ed as a materials manager. The second strategy that's worked is to find one or two things that we could just start with. Like, what are a couple of things in the supply chain, in that purchased goods and services bucket, that we could say, what can we do better on? Whether that's laryngoscopes or gowns or bronchoscopes or nitrous oxide or a particular pharmaceutical. We have one of our sustain initiatives has to do with switching some of our pharmaceutical agents from IV to oral. That's a financial win. That's a win for our nurses' workflow. That's an environmental win. These kinds of things, you get one or two of those, and you really build that working relationship. So there's, I think, less of a skepticism or worry when folks are coming into the room. The environmental guy, he's going to tell me I can't do what I want to do. No, it's actually not my job. My job is to figure out ways that we can just all do things better. There's a hand in the back there. Yeah.
Sure, no problem. I'm curious about your take on biodegradable consumables. We, for instance, use a biodegradable exam glove, and I'm just curious how you would consider that to factor overall into sustainability.
Great question. I'm going to give the broad answer and the specific answer. The broad answer is when we are evaluating a product, and biodegradable exam gloves would be one product, but whenever we're evaluating a product with respect to its environmental performance, what we would like to see are reliable, third-party verified data from the manufacturer. So what we're going to say is, you're bidding or pitching to us a biodegradable exam glove. We're going to turn around and say, okay, show me the data that demonstrate how it is superior than other products with respect to environmental performance. So I would expect a manufacturer who's making that claim that this biodegradable exam glove is better to have said, okay, well, we need to prove it. We need some data behind it, and to be willing to share those data. We are perfectly willing to keep the data that our actual and potential vendors share with us confidential. We do it all the time, obviously. So we're perfectly willing to do that, but we would ask to see it. And to that end, we would scrutinize it for real-world application. And where that goes is getting into the specific answer for biodegradable gloves. For the most part, I have yet to be convinced of a biodegradable exam glove that is environmentally superior to a nitrile one, because primarily they're all ending up in standard municipal solid waste, which goes to a sanitary landfill, and that is not a good place for most biodegradation to happen. If you can show me evidence or data or something that says I'm wrong, I would be very happy to evaluate it, to read it, and to go by it. But I have yet really to see that, and it gets into what I will put in the general box of greenwashing, which isn't necessarily intentional. There is intentional greenwashing, but there's also unintentional greenwashing, where a product or a process is touted as being environmentally better, but really, when scrutinized carefully, it's not as better as one would hope it is. Other questions? Yeah, Red Hat, St. Louis. Your season is over. Sadly, it was over months ago.
It was over before it started.
Yeah.
So do you look at trying to partner with your suppliers to analyze their carbon emissions, their carbon footprint on their supply chain, and try to shorten that supply chain? For example, at our company, we're American manufacturers, and we had a hospital system reach out to us to do a carbon analysis of our supply chain. We found that we weren't shipping our products all over the world to get to a customer, it was 95+% lower than international suppliers. So you're trying to work with your supplier partners to find out where can we possibly shorten that supply chain and reduce carbon footprint just logistically?
Great question. So to repeat the question, and I'm gonna paraphrase and shorten just for because my brain works that way. Do we, as Mass General Brigham, partner with our suppliers to evaluate and then hopefully shorten or at least include in our decision-making processes of the vendors from whom we're going to buy on measuring supply chain emissions? Short answer, yes, we're happy to. So the Center for the Environment and Health, I didn't talk a lot about what the center does and its mission, but we have a fourfold mission. One of those is operational sustainability, another is research, and those two go together often in that we have the capacity within our center to do those kinds of studies, which are actually some of the studies that we really enjoy doing. So we are happy to partner with any supplier who is interested in doing better, in learning what they're doing and how they could do better. Yes, absolutely, we want to do that. And we would certainly consider those data to be compelling, right? If we can show together, oh, this is what the number is, then we have some, I don't know if reliability is the right word, but confidence in the result because we generated it, right? We know how we did it. And we'd love to do that. I think you can also tout, I'm gonna give you a little bonus here, but the shorter distances traveled do reduce your transport emissions. Sometimes manufacturing in the United States also reduces your energy emissions simply because the US electric grid is better than the electric grid in some other parts of the world. And some parts of the world, they don't have an electric grid even, and you're burning a lot of fossil fuels for energy on site, which is much dirtier than our electric grid overall. So that's another benefit. And then shorter transport times improve your resilience. So anytime that I don't need to worry about ships getting stuck in the Suez Canal, then maybe I can operate a little bit better. So yes, we are happy to partner with anyone, whether you're currently one of our suppliers or not, to do that kind of work.
Thank you. We've got one last question between you all and lunch.
Yeah. Have you worked with local media to share with community success stories you've had with the hospital or with vendors when it comes to sustainability?
Yes. One of our goals, so Dwayne mentioned that I'm on the Mass General Brigham Climate and Sustainability Leadership Council. That is our highest level group that sets environmental sustainability priorities, strategy, goals for the system. One of our 8 work streams for this year has been improving our communications. That has led to one of our communications professionals at the institution, at the enterprise, really taking the lead on climate and environmental issues, getting the word out to any media entity who wants to hear it from us. So we've been quoted in the Globe. We've had a couple of, I think, small TV segments, audio segments on radio. We love getting the word out of the things that we're doing. We have I'll call it a healthy competition with some of the other health systems in New England, one of whom I won't name publicly, who we think we're just as good at, but they get better press than we do when it comes to environmental issues. So yes, we are very interested in getting that out, and whether that's on our own or with supply chain partners, we're happy to do both. So thank you so much. I'm going to turn it over to Dwayne.